Hi, folks. Welcome to the Immortality broadcast. And I'm here today with Dr. J.P. Saleeby. He's an expert in functional medicine and biomarker technologies and a bunch of other stuff. And I've been talking to him about getting him on the podcast for a long time, and I'm excited. Thank you for finally making time to get on the podcast with us.
Hey, Ralph, it's a pleasure.
We've been talking, exchanging emails and stuff for almost 10 years now. You were kind enough in your book on adaptogens to mention us as one of the sources. How long ago was the adaptogens book? Do you remember?
Well, sure. So it was finally published in 2006, but it had been a project of mine for about 2 years.
Okay. Yep, it was a good book. I enjoyed that one, and I think a number of the people who watch our podcast will probably have seen it as well, because this is an audience that's really into herbs and that kind of stuff. So you've probably got a few fans already listening to the podcast. So that's a good thing.
Well, that's good. That's good.
For those of the people who don't know you yet, maybe just give us a quick background. I said your specialty is functional medicine. You want to expand on that a little bit?
Sure, Ralph. Early in my career, I graduated from medical school in 1991, and immediately I knew there was something that was missing in the curriculum. And even through residency training, I knew there was just something missing, the chronicity of disease, and it just seemed like we were spinning our wheels a bit. So that's when the seed was planted back then, that there was something different. I completed a residency in North Carolina and then practiced for over 10 years in Georgia, mostly in emergency medicine. So that was my first career as an emergency room doctor. And so I saw everything from birthing babies in the emergency room to pronouncing folks at the end of their life and everything in between. So it was a good sort of baptism into what medicine was about. And I really got a heavy dose of the chronicity of illness and the fact that our system was not really handling it very well. The prescriptions for treating people were just off a bit. And it was kind of this revolving door. So I took it upon myself to kind of develop my own curriculum, and I attended conferences from coast to coast, and in an A4M initially, and an ACAM, the Institute for Functional Medicine, and several others. So kind of developed a parallel practice, if you will, back in the early 2000s. I opened up a wholly integrative what we would call functional medicine practice in Savannah, Georgia. And for a number of years, I did that alongside my duties in the emergency room. But finally retired from the ER in 2013 because it was very difficult to wear two hats.
Right.
I know what I wanted to do, but I was limited because of the practice guidelines.
Right.
So I hung up my ER hat and totally devoted to functional and integrative medicine.
Okay, I can't imagine a bigger transition from a medical perspective from, the emergency room when people are arriving at your door in a critical situation in probably most cases, and whatever's wrong with them has probably reached an emergency level, right? Or you don't see them, versus functional medicine, which is more focused on preventing things and helping people before it gets to that stage. So it's I would guess that was a huge transition in terms of just how it felt as a doctor.
Right, and it was somewhat sad because by the time they reach me in the emergency room, they're in extremis. I mean, they're at the end of their rope. They've had chronic illness, let's say diabetes or renal failure, plagued them for decades even, and they're sort of at the last stages usually. And that's aside from the trauma and the things like that you would see. Car accidents and things like that. That's different. But it was the chronic illness, and that was actually we were seeing more and more as a percentage of what we would see every day. So I started out my career with 20 to 30% trauma, accidents, those broken bones, that kind of thing. Right. And then towards the end, it was about 80, 90% chronic illness.
Wow, in the emergency room.
In the ER, right?
Yeah, no, it's crazy that it's less the case now But during the 90s and the early 2000s, so many people were using emergency rooms as their only source of care, right?
That's right, and it's gotten worse. I think in the last 10 years, it's been much worse. People coming in for refills of their blood pressure medicine, the uninsured still with ACA, trying to remedy that, didn't really. And this season, actually, the flu season is one of the worst in 10 years, and the emergency rooms are being overwhelmed. A lot of them are having to set up tents out in the parking lots to handle the overflow of patients.
Wow, that's crazy. Yeah. So not everybody on the call is going to know what functional medicine is exactly. Can you just give folks a quick overview of what is your view of what makes functional medicine different than what the regular MD or their GP might be doing?
Right. So the elevator speech for functional medicine
sure.
would be it's basically a systems approach. And instead of dividing somebody up into organs, like you have a heart condition, you would see a cardiologist, right? So functional medicine doctors are typically generalists, and we like to call ourselves super generalists because we dive deep into all the different systems, and sometimes on a cellular level. Like we look at the cell or the mitochondria, we look at hormone axes, what they call the HPA axis. Everything from thyroid to adrenals to gonadal hormones. And it also doesn't stop at a diagnosis that is basically a symptom of an underlying cause. Right. So with conventional medicine, somebody might be diagnosed with MS. And so they get the MRI, they see plaques, and they're oh, you've got MS. And the workup stops there, and they get put on medications to deal with the symptoms, not necessarily cure the underlying cause.
That's one of my big complaints about medicine is this idea of treating symptoms versus treating core causes, whatever those might be.
Root cause, right? So with functional medicine, we dive deep into root cause. We try to find a reason for the autoimmune disease that manifests itself as MS. Mm-hmm. And oftentimes we're kind of surprised with things, but with more experienced providers, it's kind of we follow an algorithm, right? And we kind of don't stop digging until we find the cause, the root cause.
That's actually probably pretty satisfying for you, right? I mean, you're almost you're a medical detective in some sense, right? You're trying to put together all the pieces and find some sort of root cause.
Right. So that's the challenging part, which is very rewarding professionally, but also rewarding is knowing that we can actually cure people. Mm-hmm. So we're not putting somebody on an expensive medication that they're going to have to take their entire life to treat their psoriatic arthritis. We are actually reversing it.
I remember in one of the emails that you and I exchanged on a personal level, I have Graves' disease, which is in remission right now, and you mentioned that Lyme disease was something I should take a look at. Have you found that Lyme disease is often related to autoimmune disorders?
Yes, it's very common that everything from ALS to MS to autoimmune diseases of the thyroid, which includes Graves' disease and Hashimoto's. Right. Very often, not all the time, but very often you'll see a tick-borne pathogen as the root cause. There are other things like genetics plays a part, sure. As does environmental toxins, pesticides, residues like glyphosate, but also things like heavy metals. And then molds and mycotoxins. So sometimes these things are layered. Somebody has a genetic predisposition, they get a tick bite and they get Babesia and Bartonella, for example, and then they are exposed at work to aluminum. And the milieu of all that actually is what causes this terrible autoimmune response, which, depending on the individual, may attack different systems. Mm-hmm.
It's it's not like there's a single trigger. You find it's often a combination of things as opposed to a single root cause. And if it is a combination of things, how do you tackle that?
Sure. Well, it very often is not a single insult. It's usually a bioaccumulation of insults throughout one's life. Right. And it can even start in the birth canal. There is a difference between a vaginal delivery and a C-section.
Mm-hmm.
The gut microbiota is different.
Right.
It's different for individuals who are breastfed and those who are bottle fed,
Right.
who got soy or early in life, who have a mother who had a deficiency in vitamin D, for example. That all impacts your health for the rest of your life. And then along the way through childhood and adulthood, different exposures. So some folks get bitten by a tick and they get Borrelia, the organism that causes Lyme disease, and they're unaffected. Mm-hmm. They'll go their whole life with testing positive for the antibodies, but they don't present with any disease.
Right.
And then you have a person sitting right next to them in the waiting room who has bitten once, got infected, and has a plethora of medical conditions that they complain about.
Right. So, I mean, let's say a patient shows up in your office and I'm not sure how one goes about diagnosing that complex, combination of causes. But, once you've decided, and maybe we can talk a little bit about how biomarkers help you do that, because I'm guessing that may be one of the main tools. But once you've sort of said, like, okay, I think it's a combination of things, how do you decide where to start? I mean, obviously you want to relieve the immediate symptom, right?
Right. So you focus on the chief complaint, okay. And then you take a very detailed history. That's important. I had professors in medical school and residency training that said, if you do a very thorough history and physical exam, you can diagnose 80 to 90% of the problems without ordering a single test. Yeah. And that is very true. And unfortunately, in today's rat race kind of high-pressured medical systems where doctors are being forced to see 30 and 40 patients a day, there's just not the time. When the average time spent in the room with a patient is only 8 minutes. So that's the national average, 8 minutes. You can't obtain a detailed history, social history, family history, and do an exam.
Right, sure.
So you need to seek out the care of a doctor who can spend an hour with you, at least an hour, and gather that information. So based on the history, the presentation, the symptoms, the signs, then that sort of drives your diagnostics, whether you use x-rays or radiological procedures or biomarkers. Right. And so if a patient comes in with a very good history of a recent tick bite or a bullseye lesion, well, then we jump on and do that workup. Sure. If they have issues with fatigue or problems with detoxification or GI disturbance, well, then we might look at their gut microbiota first and do a CDSA. Right. So that's sort of what drives the testing.
Right, and the diagnostics process. So let's talk a little bit about biomarkers. I know you're an expert in biomarkers. You also sit on you're the chief medical officer for Zimetry, which is a biomarker company as well. How did you get interested in biomarkers? Was it just a natural outgrowth of functional medicine for you, or how did that come about?
Right. Well, actually, that preceded my joining and becoming a member of the Institute for Functional Medicine. But I was doing some writing for a national trade magazine for aerobic and fitness. It was called AFA, and I would contribute heavily referenced articles for this journal. Mm-hmm. It was kind of like a peer-reviewed trade journal. Okay. And one was on inflammation and the biomarkers of inflammation. But that actually stemmed from the desire to utilize labs that had actionable value. A lot of times, and a study came out in, I want to say JAMA, Journal of American Medical Association, on the failure of the annual physical exam, which was comprised of a couple of basic blood tests that were not very predictive in nature and were kind of basically a waste of time and money. Sure. Although everyone gets it every year. Right. But it has no predictive value of where to direct the patient or what are early warning signs of impending chronic illness. So that sort of sparked me to sort of rely heavily and have my practice and my patients driven by these biomarker results. and it's been very successful in helping me prevent things like renal failure, cardiac disease, cardiometabolic disease, and hormone imbalance.
So, how long ago was it that you were writing the articles for the health publication?
Sure. So that was over probably a course of 10 to 12, 15 years.
Right. So I mean, biomarkers is one of the things that I pay attention to, just because I'm a geek. But there's been huge progress in biomarkers in the last 10 years. I would think that now you find a lot more useful predictive biomarkers than 10 years ago when you first started into it. Is that, do you find
Oh,
that
absolutely. Absolutely. We're constantly adding new and emerging biomarkers, or things that maybe were not thought to be that interesting at one point. We're adding in onto our panels now. So almost every 6 months, we alter our standard panel and add and subtract things. One that's come to our attention fairly recently, and this test has been around for a while, but normal when there are advancements made in medicine, it's on average 17 to 20 years. At 17 to 20 years, before mainstream medicine will pick it up and consider it kind of a standard of care.
Right. And by the way, the FDA approval of biomarkers is so slow. Like the list of useful biomarkers that have been approved by FDA, I think I can count on, two hands probably, right?
Right. And it's what the insurance companies, it boils down to what the insurance companies are willing to pay for. Sure. But yeah, there are probably hundreds and hundreds of biomarkers that can be used. And that's just the serum analysis. I mean, we're talking, there's a huch genomic profile, and that can have a big impact in predictive nature. But there's one that's emerged called the glycomark.
Okay.
And that is a very, very early sign of an impending problem with glucose metabolism. So before your fasting glucose would change, or your hemoglobin A1C, which are used to kind of monitor diabetes or insulin resistance, the glycomark will precede that by months to years. So, one would sit back in conventional medicine and wait for that A1C to rise north of 6.5% and then say, oh, great, you've got diabetes.
Right, or you might do a glucose challenge even, right?
Right. Exactly. Or when people start having symptoms and signs of diabetic neuropathy or retinopathies, I mean, that's not the time when you should make an intervention.
Right.
So with the glycomark, you can see maybe years in advance that there may be a problem, and make some dietary changes, lifestyle modification, and maybe use things like berberine to help with modulating glucose metabolism, to prevent the body from becoming insulin resistant or becoming a type 2.
Right. Do you find that people, how do I want to say this? My experience is that people don't always respond to recommendations for health until the problem has become acute. So if you measure someone's glycomark and you say, look, I can tell from your glycomark that you're on a course to develop insulin resistance and, ultimately diabetes, and I think you should do something about it now. Do you find people are open to that message, or do you find that they're not responsive until it reaches a critical stage?
Right. Well, I think it's up to the individual. There are some folks that get it. There are some folks that understand all about prevention and know that an ounce of prevention is like a pound of treating something. Right. And those are the folks that come in that have researched our practice, researched our providers. They come in with good questions, and they will be so adherent and compliant with our plan of action that it serves them very well. It's the folks that are dragged in, like the spouse will drag in her husband. He comes in kind of kicking and screaming, and he likes his cocktails at night, and he likes to smoke a cigarette every now and then. And we could talk to her blue in the face about biomarkers, and he's not going to do much about it. So it really depends on the person coming into the office. If they're sold on this whole idea of true preventive medicine, then they're going to really benefit for decades and really live a nice, healthy life where they're retired and then they still have the energy and their body parts are cooperating so they can enjoy their retirement.
Right. Yeah, I imagine it can make a huge difference. You've been doing functional medicine, you said, for how long now? Since the 1990s, correct?
Right. And since actually I opened up my first practice in 1999.
Okay. So you've had patients who have, that you've treated, 1999, it's now 2018, so over 20 years ago, right?
Yeah, that's right.
And can you see a difference that, from someone who how do I want to say this? I can imagine that there are patients who came to your office 20 years ago and you could see they were on one path, and you look at them now and they're on a completely different path because of your intervention early on.
Right. The interventions we make on our patients that are compliant, you can see them. I am always amazed when they come in the office, and I've been monitoring them for 10 years or 12 years, and they look fantastic. And then there are those poor unfortunate souls that come into us in desperation. Right. They've found out they have cancer or some real debilitating autoimmune disease or diabetes or renal insufficiency, and they want a miracle. And I'm thinking, well, the miracle was 15 years ago.
Right, exactly, yeah.
And it's kind of disheartening. It's sad to see that. So we always preach prevention, prevention, prevention.
Yeah, absolutely. My father-in-law was just diagnosed about 2 months ago with lymphoma. He's already stage 3, and even now he's not paying attention. I mean, he'll have a lymph node start to swell up, and he just he pretends it's not happening. And no amount of conversation with him about it seems to change his attitude. It's not that he doesn't care; it's that he doesn't want to hear the bad news. It's he doesn't have any radical lifestyle behavior that I would associate directly with causing cancer. But he's one of those, stoic personality types who his when you ask him how is he always says he's great, no matter what the situation is. And, that attitude of being, tough in the face of adversity doesn't always serve one when it comes to illness. Like it's being body aware and recognizing early warning signs, even if you don't have the benefit of biomarkers and that kind of stuff, just being body aware can make a huge difference in your long-term health and mobility and activity and all that good stuff.
Some of the patients we treat, sometimes we don't really focus on the biomarkers so much. It's very obvious from their history and physical exam what might be wrong with them,
sure.
What direction they may be headed. The biomarkers then form sort of a metric instead of a diagnostic tool. So we measure at time 0 and then at time 3 months, 6 months, a year, and we can actually see a change. And it's nice when a patient comes in and sees these red marks on their report go to yellow or green.
Right,
I mean,
absolutely, yeah.
I kind of sit back and I watch them kind of smile, and they start beaming, and they realize that the work they've done is paying off.
Right. Yeah. You don't necessarily immediately see it in your health, right?
Right.
But you can look at the biomarker and go like, okay, I'm progressing in the right direction, and that's that's motivating to keep doing it and stay with the program, as opposed to a more traditional medical approach where we're not checking things like that, and you don't have a sense of progress, and maybe you've chosen a diet because it worked for your cousin Susie or whatever, right? And you're waiting for the pounds to come off, or you're waiting for your insulin resistance to change or whatever, and it's not changing, and you don't know, is it because I'm on the wrong diet, like this just isn't right for me, or I just haven't given it enough time. But when you have biomarkers that you can look at, when you can look at quantitative measurements and see that line go from red to yellow to green, then that's a different kind of motivation, I think, than just gross physical measurements, for example.
Right, exactly. And occasionally we have the patient that comes in that has no issues, that has no chief complaint, and says, I just want wellness. And we run some biomarkers, and they look like the picture of health.
Right.
I mean, they work out in the gym, they've got good muscle tone, they've got great posture and flexibility,
Right.
they eat a clean diet. And then we run some biomarkers and to discover, oftentimes with their genetics, that there's a predisposition for cognitive decline or Alzheimer's disease or diabetes or kidney failure. And we can make these interventions. And sometimes they're really shocked and like, well, gosh, I thought I was really healthy. And they are at that point, but there's a tipping point where their health would decline. And we can make early interventions to prevent that.
How often do you check genomics? Is it a routine part or?
Yeah, usually once. So we have a relationship with 23andMe to get the data set. So when you do the saliva sample, you can check off ancestry only or health. But we need both, and that will provide us with about 700,000 genetic genes where we can look at the SNPs or the variants or variations in your genetic makeup. That has to be analyzed. That's a tremendous amount of data.
Sure. And
the International Data Bank is constantly updated every day. So we can actually take the same data set and reanalyze it every year, every 6 months, to get even more new and updated information. But we only collect the sample once because your genetics don't change. At this point, we have gene therapy to do that. So that data is analyzed, and we can focus in the platform that we use at our center. We can actually focus in where we may determine let's say there's a family history of cancer. So we'll focus in on cancer, oncogenes, and how diet, medication, and other lifestyle things can affect it in a positive or negative way. So it's what we call epigenetics. It's genetic makeup, which is static, that doesn't change, but it's the environment, how it impacts your genes, how it turns things on and off, that will cause gene expression. And then it can be either a good thing for people or a bad thing. So we'll try to figure out what the bad things are and avoid those.
So how do you measure epigenetics? I mean, so a gene gets turned on or off by some environmental situation or diet or whatever. Does that manifest? It obviously doesn't manifest in a change in gene structure. Does it manifest in a change in your biomarkers, or how is that? How do you observe an epigenetic change?
Exactly. So biomarkers are kind of the endpoint of gene expression. The genes themselves won't change. If you keep running the same test on the gene SNPs, they're not going to change. But there are proteins and gene expression things that can be measured. For instance, there's a blood test that can take the place of a colonoscopy. So I'm for very minimally invasive procedures. So I don't want to have my patients go through the
They're
garden.
Not fun, by the way.
So, but it's that's the standard of care, and that's a kind of a semi-invasive procedure that can have some bad outcomes. But we have a test that measures 7 biomarkers of gene expression that will rise in the event that there's an adenocarcinoma in the making. The nice thing about this is that since you have that one mutated cell, by the time it becomes an adenocarcinoma is about 10-year time span. Before it forms a polyp is about 5 years. The test that we run can pick up a precancerous condition before that 5-year mark. So it would pick it up even before a polyp is visualized on colonoscopy.
So if you measure that gene and you see that there's that their biomarkers indicate that they might have a concern, at least in the future, would you then order the colonoscopy, or would you say, okay, that's it, it's diagnosed, I already know how I'm going to treat this?
No, if we pick up a marker that flips from green to red, let's say, so of the 7 biomarkers for the colon cancer screening test, if we pick up 2 or 3 that have flipped on, and are expressing themselves, and usually it's things like certain proteins or mRNA or tRNA, then we would say, okay, you're high risk, there's likelihood of cancer, so that's when you do the colonoscopy. But we don't just wanton, screen everyone at the age of 50. It's just it's kind of a process. It's a step. And there's another one for lung cancer. Instead of sending a patient who has a history of like a pack a day smoker for 10 years, instead of sending them every year for a CAT scan, which is a tremendous amount of radiation,
right, sure.
we do this special test with gene expressions. And if they're in the green, they bypass the chest x-ray or the CT scan for that year. Right. We repeat this blood test. It only requires 4 drops of blood, really. So it's very non-invasive. And if it comes back clean, they're good. No
right.
cancer. If it becomes elevated, we then do a high-resolution CT. And sometimes we can pick up a mass so small that it would normally be unrecognized by traditional screening methods.
Mm-hmm.
You can actually save someone's life by excising a small, non-metastasized lesion right. Well in advance of when typically a person comes in coughing up blood, and then they've got a large tumor with
right.
metastasis
right.
and a short life expectancy.
Cancer is one of those things where early detection, makes a very obvious difference, right?
Right. So typically, biomarkers of inflammation are very early warning signs. Things like CRP and fibrinogen and LPPLA2 and interleukins like interleukin 10 can sometimes give you a more advanced, level of suspicion that something's not right and you need to pursue something.
So where do you see this biomarker process going from here in terms of just the science and the economics?
Everyone's there's a lot of lip service about preventive medicine, but it's really what's out there as far as preventive medicine is not at the forefront of practice guidelines for any medical society like the College of Surgeons or Family Medicine or Internal Medicine. They're just not really there yet. But there's a lot of lip service because it's a hot topic.
Sure.
Until it's fully embraced and we decide that the paradigm of the pill for the ill is behind us and that we really need to make interventions to prevent you from getting a disease that requires medication. And the insurance companies and the actuaries that kind of figure all this out will realize that very little upfront cost for prevention can save billions of dollars, really, in the healthcare of Americans. The medical society, as we have it now, the paradigms that they use, GI doctors make a lot of money. They make their Lexus payments and their mortgage payments by doing colonoscopies,
sure.
and the vast majority of them are going to be normal.
Right.
The drug companies have a great financial interest in chronic illness. For example, when was the last time a new antibiotic came to market? They used to come to market in the 60s and 70s rather frequently. But in recent years, the interest in research and development for an antibiotic, which might be used for 1 week on a sick patient, is not there anymore. There's more money to be made in managing chronic illness like hypertension, cancer, diabetes. Look at the plaque psoriasis commercials out there. Every week there's a new monoclonal antibody drug, which are quite dangerous, to be honest, that are coming out that are FDA approved for plaque psoriasis.
Right.
So it's just mind-boggling, and these drugs are extremely expensive. There's been a tremendous increase in new drug cost and also generic drugs. It's shocking. Drugs that have been around for 20, 30, 50 years are seeing 400, 800% increase in cost. It just boggles the mind.
Right.
And it seems like it's more of a problem in the United States than it is in Europe.
Sure.
But there's obviously a great financial incentive for drug companies to want to keep the things the status quo because there's a lot of money to be made. And those pressures are exerted upon our political system and our healthcare industry.
Right. Yeah, there's a trend now, especially popular on the West Coast, for what's called concierge health, right? This idea that you go in and sort of at your convenience, they do a whole bunch of tests right there in the office, and the focus is not so much on treating an illness as it is increasing longevity. Like that sort of concept is becoming more and more popular. But insurance companies certainly don't pay for it yet.
Right. So the concierge concept, or the kind of VIP medicine, is kind of a hybrid system. Most of the time it's strictly conventional medicine. So they're not doing much more than what a conventional medical doctor would do. But they are offering an expanded menu of services. So for a rather large retainer fee up front and a monthly fee, you become a member of this kind of elite group of patients that a clinician has a limited number of. Sometimes the number is only 300 or 500 patients. That's it. It caps out at that. But it's a hybrid system because not only do they collect the retainer and the monthly fee, but they also file a claim with your insurance for each visit you have. And so they're kind of restricted under what is allowable for claims to be filed on. So they're not as imaginative or forward thinking as, let's say, a fee for service or another what we call DPC, direct primary care practice system, which there's not a huge retainer fee. There's usually a monthly membership fee, and it's not as elitist as sort of the concierge concept.
So when a patient comes in to see you, I gather you start with a physical exam.
The key thing, though, is history. So my clinicians, I have mid-level providers that do a lot of the patient intakes for our centers, and they start out with, they're given a whole hour, and most of that hour is conducting an interview with the patient. And it's a very careful interview that goes way back in their history, involves social history, occupational history, family history. We want to understand this patient, and we want to look and listen to their chief complaints. At that point, then we can do a physical exam. A pretty comprehensive physical exam only occupies maybe 5 minutes, really, but it's also very important. And then then we look at our algorithms as to what is most appropriate to order. So it may be some genetic testing, some genomics. It may be certain biomarkers based on their complaints. Let's say they have a family history of heart disease. Well, we'll focus on some of the markers for heart disease. If they have a history of smoking, let's say in college and early in their life, then we'll look at some biomarkers that may help us determine, if there's a problem with their lungs and cancer. And so then with the first battery of tests, sometimes that leads to second tier testing. Things like tick-borne diseases, heavy metals, mold, mycotoxins, things like that.
Okay, and I gather that herbs and supplements play a big part of your practice. Is that an accurate impression?
Yeah, I mean, we try as an integrative practitioner, I try to utilize the safest, easiest, least expensive, and least harmful and least invasive things. So oftentimes we start with lifestyle modification. We help people understand the importance of exercise, the right type of exercise. HIIT may not be HIIT, high intensity interval training may not be the right thing for everybody. So we're not going to just write a cookie cutter prescription for a CrossFit program or a boot camp type program. We need to kind of personalize that. So exercise, and then diet, nutrition. I kind of laugh and say that diet is a 4-letter word in our practice because there are so many fad diets and they don't serve everyone the same way. So we try to customize and personalize their dietary recommendations. And then, if it's appropriate, we usually prescribe herbals or the dietary supplements. And I do have a short list of good drugs. There are some medications that have great benefit and a low side effect profile. So I call it my short list of good medications. And if those are appropriate, we sometimes prescribe those.
Okay. Like, for example, what would you consider a good medication? So
a good medication, in some cases, people with cardiovascular disease, is baby aspirin. That's a very simple one. It has a very low side effect profile, and for those at risk, it can reduce their risk for heart attack by 50%, stroke by 30%, and that's significant for someone who hasn't had that event in the first place. So true prevention, and it could be life-saving for somebody who's had an event and the next event could be a terminal event. So, you have to keep that in mind too. It's not for everybody, but it can be a life-altering medication. Another one is metformin. It's an old drug's been around for a while. It does have some issues, but
Right.
it has utility as a hormone modulator. So it's used in PCOS, polycystic ovary disease. It's used for diabetes type 2, insulin resistance. It's used in Europe now as an adjunct to cancer therapy. There's a lot of research emerging that this really inexpensive drug has a lot of anti-cancer properties to it.
Mm-hmm.
So in certain cases, metformin in the appropriate patient might be helpful. The other drug I'll mention is naltrexone in the form of low-dose naltrexone, which has great implications in folks with autoimmune disease, cancer, and there's a lot of great emerging research from Europe and now in the United States on the use of LDN or low-dose naltrexone for a number of conditions, and I've seen great success with it in my practice.
Okay, mostly autoimmune kind of stuff, right?
Mostly autoimmune and immune enhancing. A lot of my chronic Lyme patients are benefiting from LDN in a post-treatment protocol.
Right. I'm curious, what's your personal diet like?
Well, I cheat a lot. So
Okay.
I eat healthy. I don't eat a lot of processed foods. I eat real food. So I'm not jumping on the bandwagon with, like, say, a paleo or ketogenic diet necessarily. My wife and I enjoy real food. We enjoy preparing. I like to cook.
Right.
And I like to use fresh ingredients, organic if I can get them.
Sure.
But we just rarely eat fat. We don't eat fast food, so we stay away from the sort of the fast food chains. We don't eat a lot of saturated fats. A lot of clean, organic meats, grass-fed beef, that sort of thing.
Right.
Lots of fruits and vegetables, and really cutting back on the grains.
Sure.
I like to make bread, so I acquired some kamut, which is a kind of an ancient wheat grain. You're probably familiar, and so now that's the kind of the wheat that I use when I make my homemade breads.
Yeah, cool. And what about exercise? What are you doing? I know you used to be a very serious weightlifter.
So, well, early on in my high school and collegiate career, I was a swimmer. I was a breaststroker and long distance swimmer. That got me through college as a competitive swimmer, and then from there I had a 2-year stint with luge. I was a slider for a bit, and it was kind of like the Jamaican bobsledder. I was living in Georgia where we don't have snow,
right.
And I would go train up in Lake Placid at the York Training Center, and had some Olympic medalists that would be our coaches, and they would joke and say, well, you're like the Jamaican bobsledder.
Exactly.
But actually, residing in Savannah, there was a team that trained Olympic athletes. Several leading Olympic team members would train there or got their start there. And I was kind of their impromptu doc. I would help some of the athletes with some ergogenic aids that were IOC compatible, that were not banned. And they got me behind the bar one day to do a snatch and a clean and jerk, and they said I was a natural, and my head got real big. And so the next day I started training seriously and competed for about 4 years.
Yeah.
I did Olympic style weightlifting, which is the clean and jerk and the snatch, and went on to compete in a master's level. I kind of retired from that to make sure I wasn't going to get myself in a situation with an injury as I was getting older. So I kind of retired from competitive lifting in 2004 or 2005.
Okay.
And what I do today is, I do a cross of exercises. I like bicycling. We'll get on the treadmill, the elliptical. We'll do free weights. Nothing really over the top, but just daily movement. So it's always good to constantly move. You need movement every day, whether it's a Tai Chi class or yoga, or just a brisk walk for 45 minutes. Sometimes that's what you need. And you need to do it throughout the day. There's this whole kind of athletic couch potato thing where, and a study was recently published showing that 1 hour of intense exercise in the gym does not make up for laying on the couch or behind a desk for 8 hours. So you got to have constant movement in your day.
As a society, I think we're addicted to anything that looks like a quick fix, you know?
Right.
But I think the approach you just described makes a lot more sense for most people, which is, eating sensibly and in moderation, and exercising with a variety of exercises, and consistently. I mean, I think that makes sense.
There's not this magic pill or shot or procedure, or there's not this magic book to read. It's really having to look at the whole person, take a very holistic approach to good health and wellness, and it's a constant activity. You can't put it on the back burner. You have to kind of make it sort of a priority in your life, because you don't want to get underneath or upside down on your health. Having a chronic illness can be so debilitating, and people get depressed, and they just go downhill rapidly from that. So you want to stay on top of it. You want to stay north of that. And you need a good practitioner who understands those things, who can actually conjure up or curate for you a very personalized, individualized program. It's not going to be a cookie cutter, because, again, not one particular thing works great for everybody. And so you have to look at what we call the 4 Ps of medicine: precision, predictive, and also the personal. You have to get people engaged, so it's participatory. People have to participate in. Doctors aren't there to dictate by fiat. Do this, this, and this. I tell my patients I act as a consultant, and we kind of reach an understanding at the end of the visit about what direction to take. And I'm kind of like the referee. I make sure they don't go outside of what's good for them. So.
Yeah, I think that makes a lot of sense. The customized approach to health, I think, is a key for a lot of people, because I think our medical system is designed around sort of this cookie cutter medicine. Everybody gets the same physical, everybody gets prescribed the same drugs, everybody gets prescribed some standard dietary pyramid that's supposed to work for everybody. And I think you're absolutely right that this idea of customized solutions and customized recommendations based on the individual's needs and their gene makeup and their life history, and even things like their personality and their behavior patterns, that's what works for you might not work for me. What works for me might not work for you. And all that stuff has to be taken into account, I think, in order to be effective in preventing long-term illnesses and chronic health conditions. So I want to just say thank you for coming on the podcast. I really enjoyed the conversation, learned a lot. I hope that the people who are listening in did as well. And hopefully you'll come back on sometime, and we'll talk some more. I want to get more into. I know you're an expert on Hashimoto's as well, right?
Right.
Based on the emails that I get, I think there's a lot of interest in from the people in our podcast on thyroid issues and Hashimoto's in particular. So if you're willing, I'd love to have you back on sometime.
Sure. Yeah, I did a chapter in a book a couple of years ago on thyroid disorders, and I'd love to come back, Ralph, and have a discussion about thyroid disorders.
Great. Thank you so much. I appreciate your time. Have a great day.
Okay. Bye. Thanks, Ralph.